So I'm going to talk a little bit about the FPWR-funded study on the Modified Atkins Diet, and I will focus more on the microbiome data that we have, and I should have more information to present, hopefully, at next fall's session, because we should have the twin study finished. So I don't have any disclosures, and this particular study has been graciously funded by FPWR Canada, and I don't really need to spend a lot of time on this, that, Prader-Willi syndrome, has a neonatal presentation that everyone's familiar with, and then there is weight gain that's accompanied by some problems with satiation, problems with the hypothalamus and pituitary, in addition to behavior issues, which include obsessive-compulsive behaviors and anxiety. And if we look at what's used for diet, and this actually is, there's a standard feeding during infancy to optimize growth and brain development, and I'm sure that that when Dr. Dweese is presenting her information right now, we want to emphasize to families of young children that we don't typically cut calories during the first year of life. We'll go at the lower end of normal because we want to make sure you're getting all the protein, carbohydrate, and fat you need to mature the brain. But then as you get older, most kids wind up having some degree of calorie restriction with supplementation of vitamins and minerals, in addition to implementation of food security during childhood and adulthood. So this may be a typical example of a Prader-Willi diet plan. And this was taken closely from one of the group home settings for what they might typically serve. And if we look at the rationale for consideration of a ketogenic diet in Prader-Willi syndrome, it's actually been used in the past. As far back as 1977, it was used in 3 or 4 adults, and they saw very safe weight loss with maintenance of muscle mass, and it was again relooked at in 1991. And it's known that ketogenic diets suppress appetite gain following weight loss because they also affect ghrelin, and folks are fairly familiar that there are abnormalities in the ghrelin profile in Prader-Willi syndrome, and this was referenced in a couple of papers. And if we actually look at the complex mechanisms for how the ketogenic diet can work, the food that you're consuming that are in a ketogenic type of diet, they change fat metabolism to some degree and increase beneficial fat profiles. They also can improve how sensitive the body is to insulin. They change the gut and the bacteria in the gut because there's different food that's coming in. They're getting a different buffet. And then this change here can actually go to the brain and then change the type of food that the brain is getting, in addition to cutting down on inflammation. And there also are some beneficial things that are seen in the brain that may help with memory and may help with behavior. Most of this data has been done in animals. And if you look at what a modified Atkins diet might look like, we're looking at somewhere in the middle. A ketogenic diet has very little carbohydrate. That's the little green bar here. And it's only about 2% of calories, with 8% for protein, and the majority is fat. With a modified Atkins diet, instead of it being that very small wedge of carbohydrates, it's about 6%. A typical diet has about half the calories coming from carbohydrates. And if you're looking at doing that, in children it would be around 10 to 15 net grams of carbohydrate per day. In adults, it's about 20 to 25 grams of net carbohydrates per day. And with most of the either ketogenic diets or modified Atkins, there's no calorie restriction, because the fat to some degree will cause some restriction in appetite. And a sample, here's an example, and I apologize, I didn't realize this wouldn't project well, but this might give you an idea of what a modified Atkins diet looks like in Prader-Willi syndrome. So for breakfast, you might have an egg and cheese quick quiche. Then you might have for a snack in the morning some string cheese. You might have, it's not real mac and cheese, but it's a modification using some zucchini some zucchini and then Parmesan shreds to make a modified mac and cheese with some chicken breast, and then some turkey caprese meatloaf cups. And then for dessert, it's chocolate mousse. But again, it's not your standard chocolate mousse. And this is all small portions. The net grams of carbs on this particular day was 8.9 grams, and it's around 1,100 calories. So that might be what that would look like. So the study itself, which was funded by FPWR, had 3 visits, and then included a sub-study that looked at the microbiome, and then we watched to make sure it seemed like people were following the diet to make sure it was balanced and that they were getting the ketones checked to look for compliance with the diet. And this was approved by the Hopkins IRB. Inclusion criteria, you had to have Prader-Willi syndrome, and you had to be in the BMI range of at least the 75th percentile. There were some exclusion criteria in addition to hypercalciuria, because there is a risk of developing kidney stones from doing the diet. If you had multiple food allergies, that could make it problematic. And if you had underlying abnormalities in how the gut worked, the thought was that having a very high-fat diet could be hard to empty out of the stomach. So we screened 16 patients, and just like other people have said, it was hard to enroll. Some of the kids said that they just could not give up their carbs. So we would get them down there, show them what the diet would look like, and the families weren't able to do it. We were able to enroll 7, and out of the 7, 4 completed the diet. 2 were unable to comply with the diet when they went home and tried to implement it. And then 1 patient dropped due to having an elevated urine calcium to creatinine ratio. That particular patient, who was dropped from the study per protocol, actually continued on the diet and has not developed any kidney stones. They just did this off protocol. And these were the patients that we enrolled. BMI Z-score is a surrogate for how heavy you are. So again, we had 1 patient whose BMI was in the normal range. And then we had a couple of very heavy patients, and then we had some that were mildly overweight. And the mix of the patients were about 3 UPD and 4 deletions. The weight change during the diet, again, this baseline is at the bottom after the diet, or during the diet trial here. This would be 4 months in and then off the diet. And what you can see is during the time that they were on the Modified Atkins Diet, weight was either stable or there was some slight weight loss, but then once they came off the diet, patients' rate of weight gain went up a little bit or still remained stable. Again, small numbers. And then labs during the diet, as you'd expect, if you are increasing the amount of fat in the diet, you're going to see a change in the lipid panel. This is individual patients, pre and post diet, with cholesterol increasing for the majority of patients, 1 to a very significant degree. The LDL, which is the bad cholesterol, again, increasing significantly for 1 of the patients. And then triglycerides were relatively stable. The hemoglobin A1C either was stable or decreased. And then insulin resistance, again, because you're having less carbs, for most of the patients was decreased. So there's some other data that will be presented in the manuscript form when I have the data from the psychologist. And then I'm going to focus now on the microbiome study, which was part of this. So if we look at what the microbiome is, who's familiar with it and has read anything other than maybe like the New York Times? A few people, okay. So if you look at what we are, we're made up of cells, but actually we're outnumbered by the microbiomes. They could easily take over Donald Trump because there's 100 trillion of them inside of us. If you weigh them, they weigh about 5 pounds. The microbes outnumber us 10 to 1, and the majority live in the gut. They aid in why they're there is they kind of live with us. We're kind of a mutually beneficial relationship. We can't fire them. We can try to cut them down, but they're still going to be there. They aid in food digestion. They help regulate immune response. Those are the benefits to us. Plus, they produce B vitamins and vitamin K that we need. And why is this important? It's essential for how we develop. When we're born, we are colonized in the womb with a small number of bacteria. With birth method, you get exposed, and then over the first 2 years of life, you actually start to develop what you're going to have for the rest of your life. It's essential for immunity because we know that there's abnormalities in the microbiome that are seen in diabetes, multiple sclerosis, and muscular dystrophy. And it's also essential for nutrition, again, for the helping with getting more calories out of the food we eat, in addition to making the B vitamins and vitamin K. Am I talking too fast? Okay, just making sure. Oh, and I am doing fine. Good, 10 minutes, okay. In. All right, so then if we look at the role in obesity, there was some wonderful papers, a lot of these have come out of WashU University, where they have looked at differences in bacteria, and they found that the gut microbiome is different between obese and lean twins. In obese twins, they have less diversity in the bacteria, and they have more bacteria present that help scavenge calories from food. So it may explain why if 2 people are sitting in a room and they eat the same plate of food, one person will maintain their weight, the other person may gain weight on the same amount of calories. I always thought it was the fidgety person that was the one that was losing weight, but it may be the fidgety person's more likely to lose weight, plus they have the more beneficial bacteria. And if we look at the microbiome and microbiome and behavior, this was a wonderful paper that's hard to read, but they have a very nice video in there. It was by Matoli et al. And they looked at mice that either received a regular diet, a high-fat diet, or received a high-fat diet plus a beneficial bacteria. And what they found was that there was an improvement in social skills and brain plasticity in the patients that received a change in diet with the an addition of beneficial bacteria. So there may be a role with crosstalk between the gut and the brain. So we decided to, again, in a sub-study, look at the Modified Atkins Diet in Prader-Willi syndrome, and this was run through a program called RNA sequencing with an Illumina spectrum. And by the time when we initially submitted the grant, it was going to cost a lot more, but the technology's improved. This allows for high resolution looking at what type of bacteria are there, and then you can do some specific programming to look to see what type of bacteria are there and infer what their role is. Gives you an idea of alpha and beta diversity, which is who's there, how many people are there, and what kind of neighborhoods you have. And then it allows for, and then we also then ran some analyses to look at what there was between the parent and the child and pre and post diet. So even with the small numbers that we had, we did find some interesting data. So we, again, had stool specimens that were from parent and child for a total of 5 patients, and then for 4 out of the 5 patients, we had both pre and post diet. And this is a beautiful picture here. Can everybody see colors here? So at the top here, we have an individual patient. This is the parent for patient 1, and then this is pre and post diet. This is the parent for patient 2, and this is pre and post diet, and this is parent for patient 3. Again, pre-diet, 4 pre and post-diet, and then 5 pre-diet. And what I'd want you to take away from this is if you look at the first cluster here, you can see that there are differences in the color patterns, which gives you an idea of what bacteria the parent has versus the kid. So you can see that there's a difference here because there's a bigger purple bar for this parent versus this kid, right? Everybody see that? And the same way if we go to 2, here's the parent's profile, here's the kids. So they're living in the same house. This is from, somebody in the same house. They're eating a lot of the same foods, not exactly, but you can see that there's a different signature between the parent and the child with Prader-Willi syndrome. And some of it's a little more powerful than others. And then if you also then look at what changes with the diet, you can see that some things are changing in the colors for the patients as they go through the study. And this is partly what all those analyses are looking at. Everybody with me so far? Okay. All right, and then this is another way to look where you can look at how common something is, what the frequency of bacteria are. So in dark blue, that means there's less there, and as you go over to yellow, it means there's a more abundance of this particular bacteria. And again, if we look, here's one participant up here, here's number 2, 3, 4, and 5. And again, the parents are all in the white bars, and what you want to take away from this is that there are differences in the types of bacteria that are there between the parents and child. It's just a different pictorial. It gives you an idea of relative abundance. And this goes down a little bit further where it's kind of comparing across the patients and looking at commonalities between the different patients and the bacteria that were there. So to take, for a good example, with participant number 4, this was the parent for number 4, and then this is pre and post diet. And you can see that some things are changing, especially down in this area with before and after the diet, because you can see differences in color. This is more sophisticated looking at what changed with the diet. This looks at how far away am I from my parent? So the closer that my dot is to my parent, this means how close the bacteria are and is it changing. So the bigger the distance, the more big of a change. This is, for this patient here, the parent's bacteria, the amount of bacteria that were there was up in this area. And then before the diet, there was a marked distance between the type of bacteria that were there, and then it actually became more diverse after the diet. And this is, I apologize, the lines are gone. This is patient number 2. This is pre-diet. Again, you can see there's a difference away from the patient with the beginning of the diet, and then this is after the diet. And there was a similar pattern for all except for one of the patients. So with the diet, it's changing things. There's differences between the parent and the child. And if we look at within the samples, again, the bigger the diversity, that's beneficial. And what we see is that with the parent, there's a difference in diversity between the parent and the child. And post-diet, there's a change in diversity suggesting that something's happening. If you look at some changes in interest of particular bacteria, I'm just going to give you a few. This one here called Tersi bacteria, it's a marker of gut inflammation and brain inflammation. What we see with the diet is there's a difference in the amount of that particular bacteria in the parent versus the child, and we actually see that there's a change in the amount of that bacteria that are present before and after the diet, and that there's definitely a difference in signature there, so that would be worthwhile to follow up on. And again, small numbers, can't really say a lot. And then Clostridia, which is an anaerobic type of bacteria. Again, differences between parent and child. And then before and after the diet, there's a marked change in that particular bacteria. Same way with energy metabolism. There are changes in the gut with how things are being eaten and exposed, both pre and post diet. And also in some of the things with how the bacteria are metabolizing things. So if I go back here, I've talked for a few minutes on what happens in the gut and what type of bacteria are there. Again, small numbers, but people have anecdotally said that there are changes that they see in their children when they go on a modified ketogenic diet to some degree. For most patients that they do this, weight maintenance and weight loss are definitely available. There is a shift in lipid profile, so it's not going to be one size fits all. If your child if you have a family history of cardiovascular disease, if you have a very abnormal lipid panel going in, this is probably not the best option for you. Just like if you look at medication profiles, it's probably not going to, one medication is not going to work for everyone. And also if you have a family history of kidney stones, again, probably not a good option because there is a risk with this. There is some impact upon gut microbiome, whether this is going to be good or bad and whether this is going to play out to show that there's a relationship between cause and effect. I think looking at a larger number of patients and then getting some feedback from the second study that I'm hopefully finishing off by the end of December, which is looking at twins with Prader-Willi syndrome and triplets, where we're looking across a number of patients, both identical and fraternal twins. There may be benefits. People are shaking their heads. You're shaking your head?
Yeah, it's amazing. It's just unfathomable to think of studying twins.
Yeah.
It gave me a moment of like, wow.
Yeah, so there's been some differences in twins that I've noticed over the years, and I've not been able to figure out why, if you're identical twins with Prader-Willi syndrome, there are many different things that could be there, but what is the difference and why is there something? So we were funded by FPWR, and it's taken a long time to find twins, and both identical and fraternal, to try to collect and then look and see if there's something there, because I would think there's going to be a signal there. We should be able to correlate that in a much quicker way than looking at other things. I wanted to also mention, with respect to this, I would be very leery about just going home and throwing a bunch of probiotics at your child or taking somebody's poop and everybody has their crap, right? So what I wanted to make sure I put a caution out there about was please, don't go home and then decide you're going to brew somebody's poop, somebody that you like. It's like, okay, like people now can go to a donor bank and pick who they want to be the father of their child. What I don't want people to go home from here today is think that, okay, we can see here that there was weight maintenance with using this modified Atkins diet. I don't think my child can do that, but maybe I can find somebody who has done the modified Atkins diet, who's done well, and I can get their poop and just shoot that into my child or my adult, okay? I don't want people to do that because there are some concerns with stool transplant that we do in GI on a regular basis. And I don't know if anybody has seen this before. There is a big warning from the Food and Drug Administration that whenever you meet with somebody, right? You meet with somebody, everybody has their baggage. So you're then taking somebody's crap and their baggage and putting it into yourself. And we do this not infrequently in GI for patients that have Clostridium difficile diarrhea, which doing a stool transplant's been very beneficial, but there have been some side effects with doing it. And there have been, at least with just doing that with a screened population, some risk of bad infections or picking up drug-resistant bacteria including a couple patients that develop bad infections after transplant. And then there's also concern for passage of cancer risk. So with the microbiome, I think there's some promising early data. What I want to do is correlate that with the psychology questionnaires. I had hoped I'd be able to present that today, but I just have not received that back from the psychologist. And then I want to look at what happened with the microbiome in the twins, because I think that'll be very invaluable. And then I can come back and talk to you guys further about that. And I wanted to then lastly recognize the people that were part of the study team, which included a gentleman from the USDA who helped with the anxiety questionnaires, our research unit at Hopkins, the microbiome lab at Cindy Sears, and notably James White, who ran all those analyses. And then I wanted to definitely thank the families that participated in FPWR Canada. And thank you. You can just yell.
I'm a little confused. You say that like most people's microbiome is set at age 2.
Yes.
And yet, are you changing that?
Yes, you can. If you think about it, depending on what buffet is available, some of the people that are at the buffet are going to change. So there are some things you can modify, but the issue with that is most of the time the modification is short term. So if we look at somebody who's like, for example, with if you do a stool transplant for C. diff, in some people those bacteria will stay for a long time, but for other people, it will only last for a short period of time.
And that's because of what happens prior to the age of 2?
You mean for the bacteria in the gut? No,
well, you're saying some guts act differently than other guts, correct?
Right.
So some bacteria will stay in one person but not stay in the other.
Right.
And is that a biological difference of people, or is that based upon their baseline?
It's probably it could be a combination of both, because there are some things that we know about people that are different from person to person. Motility can be different from person to person that could allow for one particular bacteria to stay longer than another one. And then if you look at families, again, you can see there were differences across. There were a few things that were similar, but not across the board.
And so also with the diet, are the microbiomes the changes, are those microbiomes dying and then being replaced because what the person's putting in their mouth? Or are those microbiomes just, I guess, reducing in population? I guess would be the same thing as dying.
Can I tell you that they're totally being obliterated? The answer is probably no. But the relative abundance is changing. Because I would say if I go back to data from the Clostridium difficile, what we know from that, again, that's not Prader-Willi, is that there's probably still a small number that are present, but the other bacteria, the beneficial ones that you're getting with a stool transplant are recapitulating what would be more normal, to give you more kind of normal background. If you look at a neighborhood, what you're doing with either the diet or with taking a probiotic, or if you're doing a stool transplant, is you're changing the gangs. You're getting more of the good people in, more of the good police. Hopefully police are good in most places. And you're getting a little bit, you're cutting down on the number of bad actors. You're probably not totally getting rid of all of the bad actors, but you're shifting the balance.
And how quickly does that happen? So if I give my daughter plenty of vegetables on Monday, but then I give her normal diet or a bad diet Tuesday, Wednesday, Thursday. So Friday, are those vegetable microbiomes still in her system, or are you talking?
Usually, if you look at what again, this is all hand waving because we don't have hard data, but it probably generally, you're not going to see something that quick, like only like 1 or 2 days. Usually it's going to take probably at least 5 to 7 days of doing the same thing consistently to really see a shift. But then if you want to keep that shift going, you're going to have to keep, whatever the intervention was, you need to keep that going because you want to continue to keep that population there. Yes?
I'm curious to know about the impact of antibiotic treatment on the microbiome, both in terms of its immediate impact but also re-establishment after.
So that's a very good question. If you look at the diversity of bacteria, being exposed to antibiotics very early in life, it definitely sets you up to have more bad actors, and to have less diversity of populations. The same way with being born by a C-section. You're not getting exposed to some of the normal things that you should be. Yeah, and then depending on what antibiotics you take, if you have, for example, somebody who had a stool transplant who suddenly, like 2 weeks later, goes on antibiotics, whatever good you had, it's gone. Yeah.
I'm curious, what questions should parents be asking to know whether or not to consider a modified Atkins diet? And if they were considering that, what professionals should they bring into the fold to make sure that they're doing it properly?
So if you're going to consider it, I mean, again, there's different levels of what people do. If you look at most people are cutting carbs to some degree anyway. And you're making good choices about what carbohydrates you're giving your child, because you're going to give your child fruits and vegetables. You're probably not going to give as much of carbohydrates, you're not going to give as much French fries, not as many breads. You're going to do more whole grains. So you're picking actually the healthier types of carbs anyway. Do you need to go all the way to... I can't get it to go back. Go all the way to a modified Atkins. I don't think so. What I don't know is how much of a change you'd have to make to be able to see benefits. I honestly think that you could probably go somewhere between a modified Atkins, which is like 6% carbs. I honestly think you probably would see still benefit if you were getting 10% of your diet from carbohydrates. That's still going to be less than what the typical thing is. But if you're choosing wisely, you probably could find somewhere in the middle. And the people that you definitely would want to bring in before you did that would be, one, you want to bring in a dietitian who's very experienced in pediatrics and has some background in Prader-Willi syndrome, so they can give you a good idea of what type of protein you want to have. Are you getting enough vitamins and minerals? And then to give you some suggestion of do you need to do additional things to support growth?
And then my second question...
And then you'd want to monitor labs, sorry.
No, good point.
Yeah.
My second question was, you made a remark that we should not go out and just add probiotics, but when would be the right time to consider that? And if you did, are there certain brands or certain types of probiotics with certain bacteria that we would want to include in the diet?
Sure. So I'd say as an infant, the best thing you can do is probably try to breastfeed if possible. I think that's probably the best thing, because you're going to then engineer with healthy bacteria. You want to try to avoid, if you can, things that are going to change the microbiome. So if you have an infant, you probably don't want to have them take proton pump inhibitors, which would be like Prilosec, Prevacid, Nexium, or Protonic. So that's, again, going to probably change the type of bacteria that are there. You want to be judicious with use of antibiotics. And then for probiotics, probably the ones that have some clinical data, again, not in Prader-Willi syndrome, but across the board, would be Culturelle. At least if you're giving that you know what you're getting out of it. You're also going to see that with Florastor, and you're going to see it with NSYNC and Align. But getting it from food and giving healthy food is probably healthy food, kind of natural things with not as many preservatives are probably going to be very beneficial. And then minimizing artificial sweeteners, because there definitely is some data that artificial sweeteners cause some not beneficial things in the gut and the bacteria.
Thank you.
Yeah, hopefully that was helpful.
Hi, I'm just curious. Our daughter's 7, and we've done no grains, no sugar, low carb diet, and she doesn't have any hyperphagia yet, thankfully. I just don't know if you'd seen in other people, like if you followed that diet from the beginning, does that affect when hyperphagia may set in, or has that been seen at all?
I don't think we know. I think that would be partly something to get into the natural history study for what type of diet you're following and what symptoms you're having. Because again, it's hard to say with limited experience, whether that's going to pan out or not. So, I can't say for sure.
Okay,
yeah.
Thank you.
But I can definitely say that patients that have marked hyperphagia, that for other reasons have gone to some degree of carb restriction, that there's been some beneficial changes. Yeah.
In looking at your slide about the risk associated with shifts in lipid panels associated with adopting this diet, are the drugs that are out there to manage that available, and would they be effective? And I don't even know if young people take statins, but
so statins can have some problems with patients that have mitochondrial disorders. So again, if you're picking things, again, one size is not going to fit all. Right? Yeah, it's a risk-benefit ratio. Yeah.
Okay.
And there's already in the background the risk for thromboembolic events or clots in Prader-Willi syndrome. So I think it would be kind of an individual discussion. Yeah.
Thank you.
Sure. Any other questions? Okay. All right. Thank you. I appreciate it.